Because allergic rhinitis and asthma often coexist, it is important to have fundamental knowledge about pulmonary function tests and about peak expiratory flow rate. Why we should do pulmonary function tests? These are a group of tests which evaluate the capacity of the lungs. The primary function of lung is gas exchange. These tests which are important for us are peak expiratory flow and spirometry. They are indicated when you diagnose a lung disease to differentiate between obstructive, restrictive or mixed airway obstruction, and it is part of the routine health checkup and for insurance packages. Peak expiratory flow, it is the maximum or the highest flow rate achieved during forceful expiration after a full inspiration. It is done using a portable handheld device. It is quick, inexpensive and can be used by the patient themselves. It also helps in monitoring the dose which is used for as a meter dose inhaler. Peak flow rates can exhibit diurnal variations and can vary with different devices. Therefore, patient must measure the peak expiratory flow rate with the same device each time and at the same time each day. Spirometry is a medical test that measures the volumes of air an individual inhales or exhales as a function of time. The spirometer was first invented by John Hutchison. It measures the lung volumes and capacities. We should have a fundamental knowledge about the various lung volumes and capacities while doing this test. It is performed by the clinician or by the technician who is qualified to do this test. How to perform the test? Check the calibration of the spirometer, explain what you are doing to the patient, collect the patient data. Usually it is computer generated information. You have to take the age, height, ethnicity, history, and position is very important. Patient has to have his chin lifted up and the technique has to be explained properly before actually doing the test. Repeat maximum number of 3 times. This is an example of a flow volume loop and a time volume curve. This is a normal flow volume loop below and a time volume loop above. Each test performance is considered valid when the time volume curve obtained must be of a good normal plateau. Each expiration must last for at least 6 seconds and the difference between the values of the two best 4 FVC test and FEV1 must not be more than 0.2 liters. The flow volume loop must not contain any artifacts that can occur due to faulty technique. Normal values and interpretations. Normal FEV1 by FVC ratio should be 70% and above in a normal individual. In restrictive airway disease, since both lung capacities decrease, FEV1 and by FVC ratio automatically increases. In obstructive airway disease, all the lung capacities are increased, therefore, FEV1 by FVC ratio decreases. A reduced FEV 25-75 is indicative of small airway obstruction. These are examples of normal and abnormal flow volume loop and the time volume loop. The first one is a normal flow volume loop, and in obstructive disease you get a concavity in the flow volume loop. In restrictive, the entire curve is reduced to a small size. In mixed, you have both the reduction in the volume as well as concavity is noted. So, again in a normal flow volume loop versus early small airway obstruction, severe chronic obstructive disease, in fixed large airway obstruction, in variable intrathoracic airway obstruction and restrictive disease. These are the different types of curves that you get. Artifacts are noticed when the patient, sometimes the test can be unacceptable. These are some of the examples of acceptable and unacceptable flow volume loops. So, obstructive disease, there is narrowing of the airways such as in conditions like asthma, COPD, chronic bronchitis, emphysema and bronchiectasis. Some of the examples of restrictive airway diseases are kyphosis, scoliosis which result in chest wall deformity, some neuromuscular diseases and certain medications, and interstitial lung diseases such as asbestosis etc. can cause restrictive lung disease.